All right, I'm going to talk about the hip as well, but a little bit of a different patient population. So we're going to talk about microinstability, or hip dysplasia, it's commonly called. We're going to talk about what this is, how to diagnose it, how to recognize it, what are some of the key aspects of the exam, how to interpret the images and the MRI findings, and then just kind of start the appropriate treatment. So when you think about the hip pain, a lot of times, you know, if it's an elderly patient that comes in, you think about the arthritis, and unless there's been a recent injury or trauma, in which case you think about a fracture or a bone bruise or something like that. But to have an accurate diagnosis, you need to have a systemic approach to this, and you need to kind of consider the differential to be pretty broad and consider all the possibilities. So usual sequence of events: as a patient comes in, they have a hip pain, you send them to do some conservative treatment with physical therapy. They don't get better, you get an MRI, a labrum tear. But that's not that important, honestly, when it comes to, just because there's a labral tear does not mean that we need to fix it, put them on an operating table, and so on. Better question is to ask is, why is there a labral tear? And so here on this list you can see different etiologies of a labral tear. So this could be traumatic with the hip dislocation. If there's an impingement in today's talk, instability could be iatrogenic in patients that have had prior hip surgery, or it can be from arthritis as well. I get a lot of patients that come into my clinic, elderly patients or older patients that come with an MRI and they say, oh, well, I have a labrum tear, but then there's a ton of arthritis on the side. That's an example of ignoring that MRI finding. So generally, you can group this into two buckets. It can be an impingement and a microinstability. This is in a young person. And so microinstability is not an uncommon phenomenon, but it's important to recognize it because oftentimes it's overlooked. And so if you look at these two x-rays, you know, a lot of times you would say, oh, these are normal x-rays, there's nothing, let's move on. But there's distinct features of instability here. So what is hip instability, right? So inherently, we all think about the hip as the most stable joint. But however, there is this phenomenon, and there is micromotion within the hip that can cause symptoms. So this can happen even in patients that don't have hip dysplasia or any kind of bony deficiency. So classically, it's been associated with developmental dysplasia of the hip in the newborns, and this is mostly on the acetabular side. However, there's multiple factors attributing to the hip instability, and not just on the cup side, but also on the femur side, and these need to be considered when making a diagnosis and evaluating the patients. Quickly about anatomy, we have static stabilizers of the hip. First of all, it's the bony stabilizers of the cup and the femur itself, 3 ligaments that come across the hip joint, and the most robust and strongest ligament in the body, the femoral ligament that stabilizes the hip in external rotation with extension. And then the labrum is there as well, which is the third static stabilizer of the hip. And what that does, it's a fibrocartilage that deepens the socket and provides extra stability and surface area, and also provides a very important negative hydrostatic pressure, or the suction seal. Dynamic stabilizer are the small muscles around the hip. They are associated closely with the capsule. And what's interesting that with these small muscles, they often hypertrophy in instability, and I'll explain in a second why. So to fully understand the instability and or to understand the stability of the hip, you have to look at both sides. So definitely have to look at the version of the acetabulum as well as the torsion, which is the three-dimensional orientation of the cup. The hip itself and the anatomic features provide a pretty good posterior stability. That's why we have pretty good range of motion when it comes to forward flexion or abduction of the leg. But when we're extending the leg, or if we're adducting to the side, then we're relying on soft tissue structures in the hip to provide that stability. And when there's instability, anatomical features in a patient, those structures get stressed more, and then that can lead to other issues, as I'll explain in a second. And this is essentially the other, I'll talk about it in a second, but these are the the torsional and neck shaft angle features of the femur itself. So generally, this is the vicious cycle. The femoral head does have motion within the hip, even though we think that this is a stable joint that doesn't move. A couple of millimeters in each plane is a normal anatomic motion that the hip has. And so when there's inherent instability, there's more of that motion. This stresses those dynamic stabilizers of the hip, stresses the labrum, that causes the breakdown of those tissues. That kind of feeds into this cycle of pain and disuse that causes weakness of those small muscles that are really important for that stability. And within that same vein, you get more femoral head motion and the cycle just repeats. So how do what do you see in clinic when you see these patients? They oftentimes, they don't come in and say, hey, I feel my hip is unstable. They feel pain, and pain is usually deep within the joint. They usually grab their hip like this, and we call that a C sign. It's oftentimes associated with their glutes and just generalized pain. They feel pain in when they extend their hip or externally rotate, so rotational movements. And so the exam needs to sort of focus on what their range of motion is. Every patient in my clinic gets a Baton score, because that's important for general understanding of tissue laxity. And the exam is basically done in prone, supine, and a lateral position. There's some provocative tests. These three are listed here. Anterior apprehension test. With all three of these exams, you're essentially looking for pain or apprehension. So in this first one, the force is applied down towards the ground, and you're essentially kind of levering the femoral head forward. And with the abduction, extension, and external rotation, the prone external rotation, the test, you put your hand on the trochanter itself as you're doing these maneuvers, kind of trying to push that hip outside of that bony congruence and bony restraint that it has. And so with these three tests, Dr. Stefan from Stanford has done a study. If all three of these are positive, then there's a 95% chance of predictability that there is actual there's evidence of instability intraoperatively. So just like anything, there's a spectrum of instability. So this first image is clearly dysplastic. You can see that very uncoverage of the femoral head, the upsloping surceal, and then the neck shaft angle is high. But then these other two are the ones that I showed earlier. They have more subtle features of it, and this is not readily apparent. So again, this, just like the physical exam, needs to be a systematic approach where you're making sure that you're covering everything, that you're thorough. Center edge angle is one of the parameters that I look at. It is just a percentage-wise, and this kind of determines which patients are fit on the borderline spectrum or they're frank dysplastic, and usually that line is 20 degrees. Tonus angle is also easy to measure, and it's I typically just look at the upsloping angle, and if it's more than 10 degrees, that's indicative of dysplasia. General acetabular coverage, this is percentage-wise. The crossover sign in the upper right corner is essentially if the anterior and posterior wall are intersecting, and that's usually associated with general retroversion of the socket. Posterior wall sign will generally show under coverage posteriorly, and then on the left side, the coverage is calculated as a percentage. And so if more than less than 65% is covered by the of the femoral head, that's indicative of dysplasia. Really important is to look at the femur and look at the torsion, which is something that's calculated in relation to posterior condyles of the femur, of the knee, and the version as well of the acetabulum. And then the femoral neck shaft angle is also important and sometimes overlooked as well, but the increasing neck shaft angle is indicative of dysplasia and more indicative of instability, and actually worsens outcomes after a hip arthroscopy. So there's some other subtle features. The cliff sign is basically loss of sphericity. When we make a perfect circle around the femoral head, you can see on this right image, if there's that endospheric gap, essentially, that's an instability sign. And there's also these subtle little indentations in the femoral head, and oftentimes, sometimes you can see that with hypertrophy of the tendons that are common in hip instability. So with all these in mind, we kind of go over these x-rays. So we'll skip the first one where it's pretty obvious, but on the second one, you can see that the neck shaft angle is high. It's 142 degrees. This patient has a crossover sign, which you probably can't see now that I look at this projector here. And then the third one, there's an upsloping surceal. So these are three distinctions making this patient unstable. And when she had surgery, there were intraoperative evidence that she was dysplastic. Same thing on this one. The lateral center edge angle is pretty low here, so this patient has pretty significant uncoverage. There's a cliff sign. And then if we look at the anterior wall, it only covers a sliver of the anterior femoral head. So both of these patients, when we took them back to the operating room, their distraction force was much less than expected. It was 75 pounds or less, which is very, very low. Usually to distract a normal hip takes at least 100 or 120 pounds. MRI kind of follows. Usually this is done with an arthrogram, however, with a new MRI machines that are 3 Tesla resolution, you don't need an arthrogram to do these. But I typically look at whether they have a labral tear, how big is the labrum. So if the labrum should be about 4 to 6 millimeters, but if in all planes it's bigger than that, that's a sign of hypertrophy and a sign of instability. Also look at what their capsule integrity is and how thick it is as well. And so how do you treat this? Everybody gets therapy in my clinic for whatever they come in, as my team knows, and anti-inflammatories. So core and hip strengthening needs to be the focus. This needs to be done for about 6 to 8 weeks, and this works. I mean, it works for majority of orthopedic conditions. And in this case, it's no different, 70% of success. Dr. Safran did a study a couple of years ago where he had 64 patients. Most of them were, or majority of them were female. He looked at them for about 2 years, and they all underwent formal PT for 6 weeks. And he followed them, like I said, followed them for 2 years. And 7 of these patients avoided surgery, and most of them got better. So surgically, what do we do? So frank dysplasia is obviously, it needs a bony realignment surgery, so it needs a periacetabular osteotomy or proximal femoral osteotomy. But oftentimes, borderline dysplastic patients can be treated with arthroscopy only. And what is addressed in that case? Labral tear, cartilage defects. Capsule must be repaired in all of these patients, in anybody that has a hip arthroscopy, because of that ligament that's violated with that entry. And then when it comes to cartilage evaluation specifically, microfracture does work in the hip, unlike in the knee. And you often see this pattern of inside-out lesions. So what I mean by that is that the tear pattern of the cartilage itself starts at the center of the acetabulum, and it kind of delaminates towards the labrum, which is different than you have with impingement. And you can kind of see that this enlarged labrum, the hypertrophy labrum, almost acts as a lever, and then it just sort of breaks off towards the center of the acetabulum. So in summary, so hip instability, just like anything in orthopedics, is a spectrum. It's not a binary condition. It can occur from multiple reasons, and all of that needs to be looked at closely. And again, if you don't pay close attention, you will miss it and dismiss it.